Good morning, everyone, and thanks, Joanne. And it's really a delight to be here, and in fact, closing out a fantastic meeting and a fantastic morning too. And I think that our presentations this morning continue very well from the excellent talks that we heard this morning. So I'm going to talk about optimized transplant practices that translate to outstanding survival in adult cord blood transplant recipients based on the work that we've done at Sloan Kettering, and talk about sort of what that has taught us in terms of sort of lessons for the field of cord blood transplantation in general. So I want to make the acknowledgements to a whole slew of people that are outlined on this slide, with a special shout out to our search coordinators at Sloan Kettering who really work tirelessly, and one of them's in the audience over there, and they really perform heroic work. So I especially wanted to shout out to them, and then you can see my disclosures on this slide. So our program, I started in 2006, and with a whole team of people, we have been working on the sort of bare bones of how you perform cord blood transplantation in hematologic malignancies, both in adults and children, with close collaboration with Makis Garidavou. And you could see here shown in black what we've been looking at in terms of the pros and cons of high dose versus intermediate intensity conditioning, with on the adult service having changed really almost exclusively to intermediate intensity conditioning due to the toxicity of high dose conditioning, a variety of aspects of unit selection and transplant day management. And Makis led the way in terms of the thorium infusion, and we've been assessing the post-thaw quality assessment, engraftment biology, a variety of aspects of graft-versus-host disease and infections and other complications as listed there, as well as looking at long-term survival and determinants of long-term survival and comparisons with other platforms and stem cell sources. Yanni Politicus is leading the way in terms of studying immune reconstitution, the nature and kinetics, and we've seen very good immune reconstitution in our patients and the vaccine responses. Importantly, we've been in a position because of the fact that we have a very diverse patient population, and we're doing all types of transplants, and now we're doing mismatched unrelated donor transplants, so really we're doing all stem cell donors. So we've been able to analyze the availability of stem cell source according to the ancestry of the patient, and now more recently looking at disparities in the speed to transplant and donor quality. And we've also done a little bit of a foray into combining haploidentical CD34 cells, EBVCTLs, with cord blood grafts with the help of laboratory colleagues, and in the Brenchens lab made cord blood derived CAR T cells. So if you concentrate on all the sort of nuts and bolts of a variety of these aspects of both access to cord blood transplantation and the sort of optimizing cord blood transplant practices, you can see that the result of your efforts will ultimately pay off. And you can see here the overall survival and disease-free survival of a series of patients, adult patients, median age 47, about 2/3 had acute leukemia with the Cy/Flu/Thy TPI 400 regimen. The patients were transplanted between 2014 and 2017, 90 adults, and the disease-free survival has come up really substantially because of the fact that the 3-year transplant-related mortality is progressively dropping, and the way that we perform our transplants, the relapse rates are very low. Now, there have been more recently a number of developments that have made transplants just easier and more successful, and certainly the introduction of letermovir for CMV prophylaxis, because our adults, about 2/3 of them are CMV recipient seropositive. The routine use of letermovir from day 7 out to beyond day 100, and in fact we've been able to show that in fact you need to continue this medication out to at least 6 months, has really revolutionized the way that we're managing our patients. It's just been absolutely extraordinary. It's highly efficacious with no attributable toxicity, is very cost effective, and it greatly simplifies the treatment of acute graft-versus-host disease. So I think we'll be able to show that the GVHD mortality will have dropped in some degree directly attributable to the use of letermovir. So what about recent patients? Here you see a summary of recent patients were transplanted 2020 to 2022 with a median follow-up of 10 months only. The number of patients is relatively modest because I'm showing here a standard intermediate intensity, which is a Cy/Flu Thio-10 TBI 400, and some of our patients are not fit to be able to receive that regimen, and they may get, say, the intermediate intensity regimen with 5 of thio and sometimes even less. And separately, this data is first allografts, and I have not included the second allograft recipients. And you can see here that things have morphed a little bit. The median age of these 18 patients has come down a little bit, and I think that there's multiple reasons for that. The numbers have also dropped a little bit because of the fact that in 2020 New York was severely challenged with COVID. But you can see just over half the patients have non-European ancestry, 2/3 of the patients have acute leukemia. In this patient cohort, the HCTCI is relatively low, sort of predominantly the patients are 0 to 2, and we're putting in very mismatched units. So because we prioritize quality, followed by CD34 cell dose, followed by match, so that drives down the match grade of the units. The median day to ANC is day 19, the median day to platelets has been day 35, with 100% engraftment. The high rates of GVH, but our severe GVH rate seems to have dropped a little bit. There's a variety of reasons for that, but again, it's all optimal practices because we're putting in very mismatched grafts. The transplant-related mortality has been 0. The relapse to date, and keep in mind the median follow-up's only 10 months, has been 6%, and the overall survival is 100%, and the progression-free survival currently is running at 94%. Now, obviously with longer follow-up, that won't remain sadly quite as high as that, but you can see that for this particular patient population, it's really second to none in terms of any allogeneic transplant option. And just I had to add this, Yanni Politicus is pulling out the seroconversion rates and sort of determinants of response to the COVID-19 vaccine, because as soon as the vaccines came out, I would describe it as frantic in clinic to get the patients in and vaccinate them, and they've really had excellent COVID-19 vaccine responses. So that's really been incredibly interesting and gratifying. So how can outstanding cord blood transplant outcomes be achieved? And there's just 2 basic things. The first is prompt evaluation of patient risk and donor options so that you can optimize the triage of the patient to an allograft, and the second is optimizing transplant practices. So I include this slide because it gives people a little bit of an example of some of the things that in the cord blood transplant field we're still up against. And this patient was referred to me, a non-European ancestry patient with acute leukemia, who had breast cancer, had chemoradiation, and subsequently was diagnosed in an outside institution with high-risk MDS with molecular features that dictated that she would rapidly evolve and have a lethal disease, at which point in time that was her transplant indication. She rapidly evolved to secondary AML and underwent therapy, was evaluated for all adult donor sources, had no matched siblings, no matched unrelateds. She had some donor-specific HLA antibodies to one available haplodonor, and she had major problems with availability of mismatched unrelated donors. And so therapy went on and on and on. Finally, she was referred to Sloan Kettering, and she had extremely good domestic cord blood units that could be shipped immediately, but her leukemia was completely out of control. She was immediately admitted to our leukemia service, and ultimately we decided, despite the fact that she was very heavily pretreated at this point, that we would perform a cord blood transplant, and she died on day 6. So the like the critical care staff that finally sort of looked after her with us, would immediately assume that these cord blood transplants are bad. She will be recorded in the registry as a death associated with cord blood transplant, but the cord blood transplant was not the problem. And so I think that this is something that we really need to grapple with, and we also have to actually ask the question about what about all the patients who don't make it to transplant, and certainly there are sort of socioeconomic factors associated with that. We heard about from Karen this morning, but absolutely our responsibility is to shut down futile unrelated searches, and also the donor drive. She did not have a donor drive, but other patients that we see referred in finally for consideration of cord blood have had failed donor drives. And these futile unrelated donor searches and donor drives in many instances will harm the patient. So here's our triage. In terms of we need to be assessing disease risk and transplant urgency and acting accordingly. And then we need to promptly evaluate our donor options. Many patients will not have suitable matched sibling donors, and increasingly I would prefer a young matched unrelated donor or a good cord blood graft over an older sibling donor. We then look, if they don't have a suitable matched sibling donor, at the options in terms of whether or not they would have an 8 of 8 matched unrelated donor, and we do this assessment that we call the search prognosis that Eric Davis and search coordinators and some of us have essentially pioneered, where we can very rapidly, based on the haplologic predictions that we pull off a preliminary search, tell whether or not the patient's going to have a matched unrelated or not. Very quickly, meaning within half an hour. So the patients that have a good search prognosis, they will almost invariably be able to proceed to a matched unrelated volunteer donor transplant. And for the patients that are fair, that may not necessarily be the case. And for the patients where the search prognosis is poor, immediately that we're looking at an alternative donor. And it's worth emphasising that a real matched unrelated donor is one that's both matched and provides the graft in the time required. So I think that functional inventory of matched unrelateds is actually quite small, particularly since the pandemic and other challenges to donor collections. So from the standpoint of alternative donors, which we will be able to pursue very routinely, we consider all stem cell donors, and you could see here that the patients may rapidly shuttle between donor options. So, for example, for a patient in reasonable shape that has reasonable kidney function that would permit cyclosporin use, if they have a good cord blood graft and or their transplant is urgent, we would very promptly consider a cord blood transplant, at least at this time for patients less than the age of approximately 65. But some people have a poor cord blood graft or no cord blood graft, and they will be considering a mismatched adult donor. But similarly, if the mismatched adult donor has problems, they may be back to considering a cord blood graft. And certainly we've looked at this, Warren Fingert, and I pulled this together in a Blood Advances paper earlier this year, looking at, well, if you have multiple donor options, we should be looking at not just one versus the other, but the specific characteristics of the donors in question. It's also worth noting that patients with common HLA often have very good cord blood grafts, and we found during COVID, when we had sort of last-minute cancellations of matched unrelated donors, that we emergently had to ship some cord blood grafts to be able to deal with that situation. So the second half is obviously optimizing cord blood transplant practice, and this may seem complicated, but I think increasingly it actually can be replicated in a multi-center setting. And whilst not everyone's going to agree to do things exactly the same way, in the unmanipulated unit setting, there's certain practices that we would all agree are really, I would say, mandatory and will result in very good transplant outcomes. So why isn't cord blood transplantation widespread in the US? There are multiple problems that we've been talking about at this meeting. And, I think we really, as a field, have to talk very frankly about what they are and not sort of beat about the bush, as we would say in Australia. So, Mitch made the correct comment about the BMT-CTN randomized non-myeloablative double cord versus haplo trial, that it's sort of taken as dogma in the field that the haplos were better, despite the fact that that was sort of, a borderline advantage at best. But from my point of view, who cares? Because of the fact that conditioning was being abandoned. So the trial investigated the wrong condition is no longer relevant. The results of the trial also don't stand up because of the fact that the trial didn't enforce optimal cord blood transplant practices. The resultant poor cord blood transplant outcomes have been accepted by many as the best possible outcome that could be achieved. And the emphasis was only that haplo may have been slightly better, not that the results of both arms were poor. 2/3 of the patients in both arms failed. That's a problem. And separately, despite the fact that the expansion technology is incredibly exciting, which we all agree, the investigating cord blood transplantation without expansion or investigating cord blood transplantation with expansion are not mutually exclusive. And so we have to be very careful that the very interesting work that's occurring with expansion doesn't have the unintentional effect that centres think that they can't do cord blood transplant without the expansion. And certainly the results that I just shared with you, that are shown again here on the right, demonstrate with unmanipulated units. These were all double unit grafts, but with unmanipulated double unit grafts in a significant patient population, over half of whom were non-European, the results were very good. So what about the recent series? This is a copy of our Blood Advances paper, the 90 patients that underwent the intermediate intensity double unit transplants. And by sort of coincidence, at around about the same time, another group published haplo bone marrow transplant results also with ablative conditioning. And coincidentally, it was about the same number of patients with very similar patient characteristics. And the problem is that when I've presented some of this data and in presentations before, the criticism comes back to me about cord blood is that, oh, well, your patients get a lot of GVH, which is actually true, and we're trying to sort of make inroads on that without totally abrogating the GVL and then having them all relapse. But what's not mentioned is that, yes, well, that's true, but the haplo patients with PT-Cy platform are relapsing. So I would prefer to have GVH than relapse because of the fact that ultimately I think it's going to be easier to treat, particularly given the acute GVH can ultimately resolve and the chronic GVHD burden in our patients is in fact very low. So this preferential tolerance of certain complications is, I think, sort of inappropriate. The other problem that we don't talk about is that the fact that there's been this really extraordinary revolution in cellular therapy that has profoundly impacted BMT programs and the BMT field, and cancer medicine in general, is the development of CAR T cells, and this is the timeline for the commercial approval of the currently available CAR T cell products. And that's fabulous, but the slight problem associated with that is that the majority of the junior, very intelligent, eager trainees that are coming through the doors at Sloan Kettering, they don't want to do allotransplant. They certainly don't want to do cords. They want to do CARs. And so it's basically siphoned off the what I call the young blood. And if you start talking about unmanipulated unit cord blood transplant that involves adhering to these practice guidelines that in fact you have to read, it's not exciting. Whereas these CARs, they're very exciting. They're sexy as shit, basically. And so they don't want to hear about anything else other than that. This is actually a problem for the future of allotransplant in general. So we'll see. So we just have to keep fighting. And in fact, there are myeloid malignancies that are cured by allograft. So what are the potential solutions? And this may seem provocative, but I think this is serious business. Otherwise, we may as well go to the pool. So we advocate for improving access to transplant, promoting survival, promoting quality of our life for our patients, but it's not working. So I think we need to change the discussion. So graft access is actually about racial equity. Reduced relapse is actually about GVL biology, which we don't really understand, and low rates of chronic GVHD and in fact low rates of relapse will together result in cost benefits. So what we're really talking about here is race, science, and money. That might resonate a bit more than sort of talking about isn't everything nice when you have a cord blood transplant and it goes well. So this is a slide showing that I've shown 1,000 times about the ancestry of the cord blood transplant recipients at Sloan Kettering. Showing this is not enough. So, and there's also an emphasis that mismatched unrelateds will be the answer so that you don't need cords if you don't have a matched unrelated. But in fact, it turns out not so fast because of the fact that the non-European patients are more likely to have suboptimal unrelated donors. And we just published this in Blood Advances a couple of months ago. And basically what we've shown is that the non-European patients are getting older donors relative to the Europeans, whether or not it be in the matched unrelated or the mismatched setting. In the mismatched setting, the non-Europeans are getting more mismatched donors, and they also, you have to work out multiple donors to get one. And so it's extremely time-consuming and nerve-wracking for everyone because of the fact that the donors keep flunking and you keep having to chase more. The other problem is the fact that the disparities in speed to transplant for non-European AML patients, and we just this last week got this paper published or accepted for publication in Blood Advances. 313 adult AML patients where we had the date of their transplant and their stem cell source and their demographics in terms of their age and their ancestry, and then we went backwards and pulled from the chart the date of their AML diagnosis and the date of their first BMT consult, and then analysed the timeline as to how far they got to transplant. And no surprise, the non-European patients were less likely to be referred if they were older. The referrals from outside MSK were delayed in the non-European patients. The unrelated donor transplants were very delayed, as shown here in blue. And the cord blood transplants shown here in red were fast with no difference between Europeans and non-Europeans. So I think this type of data is a big deal because people don't talk about this. There's an intention to treat aspect of this that is extremely important that we need to get into in a huge amount of detail. Also, as early as this year, in December, January, we were in complete meltdown again on the transplant floor because of the fact that we were having major problems with adult donor availability that the NMDP was sending out alerts for that you have to make sure that you cryopreserve the product and that you're going to have backup because we're having donors that are testing positive at the last minute. So there were problems with donor availability and multiple challenges at collection centres, and we also were seeing compromised quality of bone marrow collections if we could get bone marrow, which was more often the case. That was going to be a problem, in which case you had to always request PBSC. But even then, you had to have a centre that would collect PBSC. So this problem's not going away. So I think that we can't let the community forget about what happened in COVID. And COVID was a good example as why you need a cord blood inventory. There's also all the socioeconomic determinants of transplant outcome that we don't talk about, but absolutely this morning Karen's talk was a really outstanding demonstration of these issues, and we're going after exactly the same thing in terms of speed to transplant by patient ancestry. And now we're going after socioeconomic status and looking at aspects like insurance, access to expensive meds, medical debt, caregiver problems, health literacy problems, medication adherence challenges, which we have a big group working on. And Warren Fingert and I submitted to ASH an abstract where we demonstrated strong associations not only between non-European ancestry and the need for an HLA disparate graft, but with lower socioeconomic status. And so you've got this intersectionality that's a challenge for the patient. And if we go after trying to fix this, then that helps everyone. It's independent of stem cell source. We also have to go after the GVL biology, and we at Sloan Kettering we have replicated Filippo Milano's New England Journal of Medicine 2016 results, where we see no difference in transplant outcomes in acute leukemia patients according to MRD, unlike adult donors that have been transplanted with CD34 selection in this case. And we talk on and on about the fact that the cord blood T cells are unique, and isn't that interesting? But we don't really have a good understanding of what on earth's going on here. And so we have to go back to pulling the science because of the fact that there's some very interesting science that we do not have a handle on whatsoever. Luca Vago in Italy is going after this to some degree, but we really need the scientists back, which means we need money for that. We also then will have the opportunity to manipulate this biology to further enhance graft versus leukemia effects. So my last slide is a plug for supporting the transplant centres, because as much as we need the banks and we've got to keep the banks alive, the only way that we can do that, unless the whole inventory goes to other indications other than hematologic, is that you've got to support the transplant centres because we've got to do the transplants. And, with this Omicron alert in January, the NMDP correctly sent out a statement that cord blood could be considered as an alternative. But what if there's no physicians who know how to do cord blood transplant? So you're going to have to support the transplant centres and train the junior faculty, and we're going to have to pull some of them out of the CAR T cell realm because they're the intelligent young blood that you want learning about how to do a cord blood transplant. But the thing is that there's a lot of politics inside academic centres. And so to be able to have multiple cord blood transplant programs going on around the United States, for example, you need to understand the hierarchies in academic centres and the competition in terms of the research priorities and what's happening with all the money, because that's going to determine what transplants get done. You need to get the okay from the leadership, shown here with the big crown on top. It was really fun making this slide. And as well as the administrators and the finance people who are behind the scenes looking at things like length of stay. You need some senior mentors who have the will and the bandwidth to be able to train the younger faculty, shown here in their little Superman outfits. And these young faculty, they have to be eager and they have to be willing to work hard. And then you need your search coordinators as well as a slew of other allied healthcare professionals. And if you have all of that, then you're going to do cord blood transplants, assuming that you have a diverse patient population to do them in. And that's my last slide. This is a very important slide if we're going to be able to resuscitate the cord blood transplant field. And with that, I will take a few questions, and then we're going to quickly move on to Koen van Biesien's very interesting work about cord blood transplant combined with haploidentical cells. Thanks very much. An Australian.
Guy Claimer, Sydney Cord Blood Bank. Thank you, very good talk, interesting. Protecting the cord blood banks, because that's the supply of the cord blood units, it's an international problem because you need to supply based on the HLA from anywhere. Where does that conversation start as a community? General question, but how do we go to that next step of educating the young blood and making cord blood sexier?
I think that it has to happen inside the transplant centres, hence me pulling up that last slide, because of the fact that that's where these people appear, and you've got to have the academic centres working together, and then the field will follow. And you've got to have some momentum because of the fact that you can't have just cord blood transplant being this little boutique sort of operation in at the number of centres that for sort of adult heme malignancy, you can sort of count them on sort of one hand, maybe two. That's not good enough. And so that this contraction that you've seen is, I mean, we all know all the reasons, but I think that I summarised it possibly in a slightly different way. I mean, there's a lot of competing factors here. It's complicated, but I just don't think that we're going to be able to resolve this until we sort of tackle some of the things that I've talked about today. Yeah. Okay, Colleen, and then we're going to move to Koen.
Okay, this is not really totally a question, but I just want to say thank you. That was a fantastic discussion of, I think, the current issues we face in cord blood transplant. One of the things you talked about was, the trade-off between relapse and GVHD. Mm-hmm. And I think the letermovir data is very interesting because that might just change part of that equation.
Yep.
But I think one of the problems is...
And Jakafi.
Right, yeah. And one of the problems, though, is the transplant centers, right? These patients come and that's that magic 100-day, mark, and then they leave, right? So the transplant centers themselves, what they see is the GVHD. The relapse is occurring after that. I mean, I'm just sort of pointing this out, right? That
yes.
So we have to publish our long-term data because that's when the relapse happens, right?
Yes.
So post-haplo, you do your haplo, they leave at day 100, and they're like, have a happy life. It's the oncologist who takes care of the relapse. So I think that's just one thing. The other thing is just how do we empower our patient population to be able to speak for themselves too, right? So if they understood, I have a risk of likely treatable GVHD versus a risk of relapse and death, they're going to want to do the...
Yes.
Right?
They are.
So how do we empower them to advocate for their own cell source? And I know, often patients will come with a cell source already identified and a protocol already identified, and they don't really understand the landscape. So I'm just making a plug for patient advocacy as well.
Completely
advocacy groups. So, but thank you for a fantastic talk. I think the SES plays into that last point too.
Absolutely.
Thank you.
Dr. van Biesien, over to you. Thank you.
Thanks, Juliet, for indeed a great talk. And I'm happy that this slide stood here for a couple minutes, because why do we keep hanging in there with cord transplant? You sometimes wonder. It feels like a lonely thing. And I often think I'm in good company. These are 5 giants in the field, 3 of whom, one got a Nobel Prize, 3 of whom probably should have had a Nobel Prize. Probably very few of you heard of Ray Owen. He was a veterinarian at the Medical College of Wisconsin, at the University of Wisconsin in Madison, and he was the first to really describe in animals the unique tolerogenic potential of fetal immunity. And Don Thomas actually early on picked up on that. And I'll show you a slide. Jon van Rood, a mentor still to Mackie in his late age, was instrumental in developing HLA typing and HLA biology. Should have had a Nobel Prize and kept working until he was in his late 80s, 90s, probably early 90s, on trying to unravel the biology of cord blood transplant. And I'm almost sad that nobody talked about inherited paternal antigens and non-inherited maternal antigens, because it's actually probably very, very important for what we do. And then we talked a lot about Hal Broxmeyer and Larry Petz. Hal was at Indiana where I did my fellowship, and Larry I got to know very well. Both of them told me, hang in there, keep doing your work if you believe that it works. So I think with that, Don Thomas, first paper, he was in Cooperstown, New York, 1957. Very interesting paper in the New England with like 7 transplants, all failed. But he said we should look at fetal bone marrow because it's uniquely tolerogenic. So I'm in good company. But so why do we transplant? Because it's curative therapy, particularly for AML. Why do we not transplant? Again, I should thank Karen for pointing out that a big factor of this is people don't have access, and I don't think that can be overemphasized. I feel I neglected this. But in addition, when the patients are there, a lot of referring physicians and a lot of patients, rightly so, are scared of chronic GVH. Chronic GVH, particularly in the older, is a horrendous complication that affects not only quality of life, but also length of life, and there's strong data for that. There's also no donors. Now we think we've overcome that, but even when we have these donors, there's a lot of relapse, and there's non-relapse mortality. So we have haplo, we have cord, and as Juliet says, this is a failure for both. I won't dwell on it, but these were relatively good risk patients. And yes, the primary endpoint was not met. Both were disappointing. So I think we need to do better. Why then do most of the centers move to haplotransplant and not to cord blood transplant? Because even though equivalent, haplo with post-transplant cyclophosphamide is convenient, it also has slow engraftment, but it's more reliable. Once patients start recovering, they recover reliably. And these 25% of patients who are very slow to recover in the cord blood transplants are the ones that cause all the problems. They're in the hospital for a long time, they have opportunistic infections, and they never fully recover. They cost the transplant centers money, let's face it. They cost beds that are already expensive, and we have no nursing staff. So it really is not a very practical procedure because of these outliers. And when we talk about medians, let's be honest, the medians are not what counts. It's the outliers that counts. So it's the range. And it's clearly more of a problem with our cord blood transplants. We've all known that for a long time. So that leads, this erratic count recovery leads to these problems and makes it indeed, you use the word boutique operation. So I use the same word. It's a boutique operation, and we need to get over that. So my solution, but it's not my solution, it's a solution already pioneered in 2003 by Dr. Fernandez in Spain. I never got any traction from him, but I heard his group present this in ASH, probably 2007 or so. What they did was a haploidentical graft, an adult graft. They do a Miltenyi CD34 selection. I'm not sure that they used the Miltenyi or another device in those days. And they combined that with a cord blood graft. And the haplograft engrafts fast, but the cord blood graft takes over and eliminates the haploidentical graft. I thought that was the egg of Columbus for some of you who know the expression in Italy or in Spain or wherever. It's so simple, and I like simple things, so I imitated it. And we simply took over their procedure, except we used reduced intensity conditioning. We used fludarabine, melphalan, thymoglobulin, tacrolimus, mycophenolate. We've added TBI to GRACE. The thymoglobulin, let me dwell on that for a moment. Clearly, it's a problematic drug, and a lot of us are having problems with it. In this setting, it's probably necessary. because two groups have tried to completely eliminate it, and it leads to all kinds of secondary neutropenia. The Utrecht group and also Juliet's group has published that eliminating it completely results in problems. We are actually right now trying to steadily decrease the dose, but we have not eliminated it yet. This was our first publication in Blood, and we showed indeed what we confirmed what Fernandez did, but this is just the chimerism. Chimerism day 7 to 14, day 14 to 28, day 30, day 180. In blue is haplochimerism in the blood, and over time it declines. It predominates in the beginning, and over time the cord blood recovers and predominates. So we essentially recovered, confirmed what the Spanish had shown, and we have ever since then been continuing to work on this, and we have now, between University of Chicago and Cornell, we have about 400 patients. So it can be done. It's a setup. You have to have CD34 selection. You have to work fast. You have to find the haplodonor, but the haplodonor can be replaced by an unrelated donor. Clearly, we have not found much following in this country, and we are probably the only ones who are doing this in this country. What are the data? We have compared over time with double umbilical cord blood in a non-randomized study, in a registry comparison with IBMTR. We have also compared with haplo-PTCY, and here we compared with the data from MD Anderson. These are confusing slides because in the publications on the left side, in the comparison with double umbilical cord, the blue is the haplocord. In the PTCY comparison, the red is the haplocord. Big mistake, but it is what it is, and I don't know how to change the slides. But as you see, compared to double cord, we had much faster neutrophil recovery. We also had faster platelet recovery. Compared to haplo-PTCY, we are almost a week earlier. No surprise, because post-transplant cyclophosphamide is a myelosuppressive drug. So quite a big difference. Graft versus host disease compared to double umbilical cord blood, much lower for the haplocords, grade 3 to 4, much lower, and chronic graft versus host disease practically non-existing, 5–10%. And again, we've now 7, 8, 10 years experience. That is really confirmed again. We've never seen bronchiolitis obliterans. We have no cases of steroid-induced aseptic hip necrosis. This works. Why do we have less GVH than the double cords? Because I think it is because we choose smaller cords that are better HLA matched. So our selection algorithm is the opposite of what Juliet is doing. We emphasize HLA matching rather than cell dose because we think the cell dose is not necessary and we need to do more analysis in this respect. But we think the cell dose is much less important than the HLA matching, plus we give ATG. Compared to haplo-PTCY, acute GVH was about the same, but we have clearly less chronic graft versus host disease than the haplo-PTCY. And that then leads to great superiority in GRFS, both compared to umbilical cord, double umbilical cord, and compared to haplografts at PTCY. Again, nobody believes this, at least nobody follows this. I think that's an advantage. And one problem with our data here is, one, it's not randomized, and second, we were not able to show a survival benefit in these analyses. So that's, had I shown a survival benefit, we would have had more of a difference. So there's other centers who have done this. This was done in Utrecht, this was done in Spain, has been abandoned there in favor of haplotransplant, but in the last couple of years, a number of publications from China have come out that I find quite interesting. And I'll show you 3 of them. And China is a big country, as you know, but as we sometimes don't realize. The first publication is from Beijing. And they treat refractory acute leukemia, mostly AMLs, and again, non-randomized studies. These are institutional practices. 42 patients had a haplotransplant, 97 had a haplocord transplant. This was published in 2019 in JTCT. Patients are young, as the data from China tend to be. What they did is, these were refractory leukemia. They gave them FLAG or CLAG bridge, then gave them a myeloablative conditioning regimen. They had choice between two regimens, TBI, Cytoxan, metal CCNU, and ATG, or a combination of busulfan, high-dose RSC, metal CCNU, GVHD prophylaxis, cyclosporin A, methotrexate, MMF. You have to believe me that platelet recovery, neutrophil recovery, acute GVHD and chronic GVHD are identical. The massive difference with what we have been doing is that the haplo here is not CD34 depleted. They just give a haplograft. As a result, the haplo wins. And very rarely do they see durable cord blood engraftment here. The cord blood probably is present for only a couple of weeks and at very low levels, if at all, in the peripheral blood. Still, it seems to have a major impact. These are the relapse rates in these refractory leukemias. So haplo alone has almost a 50% relapse rate. With the cord blood graft added, there's only a 20% relapse rate. This is non-relapse mortality, the same. This is progression-free survival and overall survival, all in favor of this combination. And I don't have time to go into it, but they even come up with an algorithm for how mismatched the cord should be with the haplo to further reduce the relapse rates. You see here 0 mismatch, 1 mismatch, 2 mismatches, 3 mismatches, and relapse rates go from 46% to 19%. So there's something there. Second paper published just this year in TCT again, and this time from Suzhou, 500 miles south of Beijing, a beautiful city with a large academic center and a great reputation in China. And a lot of their I've had the opportunity to visit there, and a lot of their early leaders were trained in France, actually. And you go there, and everybody speaks perfect French. So it's kind of interesting. So they looked at ALL, BALL, again, non-randomized, but again, same idea, myeloablative conditioning. Some of them got TBI, some of them got a haplo, the other ones got haplocord, again with ATG, 112 patients versus 64 patients, young patients again, neutrophil recovery and platelet recovery identical, acute and chronic GVH identical, but what are the differences here? With the addition of the cord that again does not have durable engraftment, you see a more rapid recovery of CD3 cells, a more rapid recovery at 1 month here, at 1 month, more rapid recovery of CD4 cells. Why that is, I don't know, but it's intriguing. And it may have to do with some interaction between the cord and the graft. And on the side, this is the minimal residual disease that is present pre-transplant at 1 month, at 100 days, I believe, and at 6 months. Sorry for the small slides. But the boxes are positive or are positive MRD. Bottom line is there's much more effective eradication of MRD in the haplocords than in the haplos. And these are the outcomes as far as overall survival, progression-free survival, and cumulative incidence of relapse, all highly significant in favor of adding this cord to this non-T-cell depleted haplograft. Multivariate analysis, overall survival, disease-free survival, cumulative incidence of relapse, for all of them, adding the cord is an important benefit. Third study, this time from the south of China, from Suzhou. These are cities of 10 million people, and this is right across from Taiwan. And there's more studies, actually. And this is not randomized, but this is a little bit more logical assessment in the sense, and this is a little bit different also in a variety of ways. One, they don't compare haplo versus haplocord. They compare cord blood versus haplocord. And if patients had a big cord, they did a cord blood transplant. If patients didn't have a big cord, less than 1 × 10⁶ per kilo, they added the haplo. And in between, they choose in between. Now, the haplo in this case, or the haplocord in this case, is a PTCY, and I hope you can see this. I can barely see it. It's again an intensive conditioning regimen. Then they give the haplograft, then they give post-transplant cyclophosphamide, and then they give CORT. And in this case, they sometimes have the CORT winning, probably because it's less exposed to this myelosuppression. Of course, they see what we saw, the patients who just got the CORT and grafted slow, the patients who had the haplocord and grafted fast. This is neutrophils, this is platelets. But, this one should have, but again, interestingly, in their refractory patients, there's a major advantage for getting a haplocord, this time over a cord alone. So that is somewhat mysterious, but may have to do with these interactions between the cord and the haplograft. But again, consistently showing the same results and an improvement in overall survival. So this is all reassuring in the sense that although different technology, it provides credence to the concept. And it shows that it can do with less technology. You don't need a CD34 selection device for what they do in China. So my conclusions, compared to double CORT, we have similar graft acquisition costs higher than those of the haplo, but our haplocords get faster out of the hospital, have fewer chronic graft versus host disease, and hopefully fewer relapses, and that is based on the data from China. Now, can you do this for these older patients? Because really, the average age or the median age of acute leukemia is 62, 63, so most of our patients are older, and the older patients are the ones who don't go in remission and relapse. And so that's where we need to do these transplants. So we were kind of in a unique situation in the sense that I've run the transplant program at Cornell for 10 years, and before that at Chicago, so I could set the rules. And we had a very simple algorithm. If the patients have an HLA identical SIB, we do an HLA identical sibling transplant. If they have a matched unrelated donor, we do a matched unrelated donor transplant. Later on, DP permissiveness came on, and we took that into account. And then the third choice was a haplocord, and if they didn't have a sibling or a relative who was haplo, then we often did a mismatched unrelated donor. So we stayed completely away from the haplo transplant program, and some of my colleagues criticized me for that. We also completely stayed away from the mismatched unrelated program that has been popularized. But this allows us to, over time, accrue data. Most of the time we use fludarabine melphalan. Our adults get Campath, like in England, and the haplocords are with ATG. As you've seen, for the haplocords, the minimum cell dose has evolved to 1.5. We've actually occasionally gone a little bit lower. And we have no age limit. So we do this up to the age of 75, 77. A couple of years ago, we compared our haplocords. By now, we should have about 100, but we compared our unrelated donors over the age of 60 with our haplocords, and we published that also in the JTCT. More minorities in the haplocords, and the umbilical cord blood matches, just to give you an idea, 6 out of 6, 12%, 5 out of 6, 66%, 4 out of 6, 22%, probably better matched than you will see with higher cord blood doses. Average nucleated cell dose of these cords was 1.9, and actually here somewhere even lower. Outcomes were exactly overlapping between the unrelated donors and the haplocords. They're not great when you go into older patients. Many have refractory advanced disease, and there's a lot of problems, and there's a lot of patients with comorbidities. So there's much room for improvement, but this is equivalent. Now, that brings me then to our last story. I'm going to tell the story of Delia, the medical story at least, in order to introduce her as a background. So she presented to our center in 2008 to Dr. Robas, and there was a family history of AML, and I'll let her tell that. But so when she showed up, we found that she had macrocytosis, she had mild dysplasia, and she had a deletion 20q. And she was fine, and she was followed for almost 10 years. until she developed deletion 20q AML with also FLT3 ITD. This is a typo, and NPM1. She got CPX and got into a very nice PR, but remained deletion 20q positive. This was 2017. So then she got midostaurin and decitabine, and that didn't really do too much. She remained in a PR, had 3% blasts. By that time, venetoclax came on for the treatment of AML, and my colleague, Dr. Robas, gave her venetoclax and decitabine, and unfortunately, no benefit. So she had 9% blasts, and by that time, Delia was 73, I believe, but overall in excellent shape, but she had received a lot of chemotherapy. So what did we do? We gave her a bridge, we gave her CPX again, and then we did a haplocohort with an unrelated donor. There were haploidentical siblings, not haploidentical siblings, haploidentical relatives in the family, but we were concerned about using them because of this issue of familial leukemia. Pre-transplant, we gave her 1 dose of rituximab, and I can't resist dwelling on this because this came up. Our EBV reactivation with ATG used to be up to 30–40%, and since we've been giving 1 dose of rituximab before transplant, it's practically non-existing, and that too we've been reporting. So GVHD prophylaxis ATG, mycophenolate tacrolimus, so there was an unrelated female donor, and then there was, who was a 5 out of 8. We always give 3 × 10 to the 6 CD34 cells. This is CD34 selected. She had no donor-specific antibodies. The cohort was A positive, CMV positive, relatively well matched, relatively low dose, no antibodies. She recovered her neutrophils by day 10, her platelets by day 24. She had problems. She had to spend some time in the ICU with pulmonary edema, with some mental status changes. She had a second run with AFib a couple months later, and she needed TPN, but I would say, as I recall, I'll let Delia tell us, but over time she completely recovered and has now led a very good life, I would say, and an interesting life for the last 4 years. Her chimerism, again, in the beginning, the haplo in dark maroon, and over time, the cohort takes over. In her case, the CD3 chimerism was always all cohort. So she wrote a book that she will tell us about. I want to end with my conclusions. I don't think I need to repeat them. This can be done, but it's complicated and you need to be set up, and it has not found traction in other centers. I actually am impressed with the data from China because it's very resource simple and therefore may be more amenable to further exploration. And I want to throw an idea out there. Thanks to the patients, many, many patients over the years, to my colleagues, my friends, and back to Delia.
Great. Okay, and I'd like to invite Colleen and Karen to come up to join the panel. And Delia, you are now on our big screen. And I know Tina was showing you a picture, but you're up there now. I want to take the opportunity to welcome you and to explain to everyone. Cohen introduced you some, but Delia is a writer and a playwright and has written many famous books and movies and wrote this wonderful book called Life on 10th, which I encourage you all to read or to listen to her read on Audible books. That really describes not only her life, but her experience with her haplocord transplant. And I'm an NPR addict, and I happened to be listening to NPR one day, and I heard a great interview with Delia, and all of a sudden she started to talk about the fact that she had a haplocord blood transplant, and of course that rang bells in my head. I wrote to her, and she was kind enough to answer me and agreed to come and spend time with us at our meeting. And I am very grateful for her to do that. And Co and I are sitting together, and you can't see us all, Delia, but there are 5 of us up here who are all people who have really dedicated our lives to cord blood transplant and banking and figuring out ways to use cord blood for many different kinds of applications. And we are just very grateful to have you here as an example of a successful cord blood story. So first of all, welcome. And second of all, we want to just talk with you about, your experience and let you tell us some of your wisdom about, what we should be learning as people who either do transplants or who, bank cord blood, and have you make it a reality for us. So I'll start with a question, but really, if you want to say something that I didn't ask you about, feel free totally to do that. We know that you had a difficult decision, and you were essentially going for what some people would have called an experimental transplant to treat your leukemia. And I know from reading your book that your sister Nora didn't choose to have a transplant and actually died from leukemia. And I also know that you were given different statistics about, what your chances were with a transplant, with different conversations from different doctors. So if you could talk about that, and also tell us your wisdom about whether doctors should give patients statistics or what they mean to a patient when you're in the midst of really, hearing about a treatment that's really gonna save your life or not.
Oh my goodness. Okay. Well, first I want to introduce my husband, Dr. Peter Rutter, who is a psychiatrist, and we had just fallen in love. We had both lost our long mates and had fallen in love about 4 months before I got my diagnosis. So it was very traumatic. It's traumatic to get that diagnosis anytime, but it was like being just pulled off a magic cloud on just with just the most terrible reality. And my sister had died of leukemia, and one of the first things that Dr. Robo said to me as a patient was, "You are not your sister." And what she meant was, under a microscope, your AML is not the same as your sister's AML. I mean, my sister didn't have a transplant, but first of all, they didn't do this kind of transplant really at all then. And also, she had her AML was different, her bone marrow was different, and therefore I could have a different outcome. And it's very, I think Dr. Robos was so smart in how she talked to me, because she understood that Nora and I were very close, and she was my older sister, and it was almost a betrayal to believe I wasn't her. Even though I'd spent my life trying to differentiate, at that moment, it felt like a betrayal. So, they said that to me, and I felt also, I think going into it, I simply had to try this transplant because Peter and I had just fallen in love. And Dr. Robos also said to me this thing that was very smart, because I am somebody who I tell my doctors, do not tell me too much. I'm a hysteric. If I read, if I Google, I panic. I go to the worst possible place. I'm a person who just lives in terror. So I would tell Dr. Robos, don't tell me too much, and I tell you, until I wrote this book, I did not actually understand totally what I had been through. And then I had to research it and talk to everybody who went through it with me and my doctors and understand it. But at the time, I really said, don't tell me. So but I pretty much would do whatever Dr. Robos told me to do. And at a certain point, she said, you have to have a transplant. And I only, and she said to me, don't be scared of the transplant, be scared of leukemia. She just changed the focus of my terror. And it was the right thing for me. And I understood then that I had to just go out with this. And I also had love, and I really have to say, I mean, I know we're talking science today, but my survival was a combination of love and medicine. I mean, I had amazing women warriors, my girlfriends, who were just backing me every second, and I had Peter in that hospital reading every medical thing that was going on, and I just advocated. And the truth is, you're so decimated from it. I mean, really, you know, I mean, I began to think of CPX as a kind chemo. It's so nice to you. It doesn't, you know, obviously it doesn't take your hair away, but it didn't make me throw up. It was just, you know, and thank God it worked and got my marrow clean so I could have the transplant. But melphalan took me out. It just completely took me out. And I stopped eating. I was just nauseous all the time. And I was not in any way running my show. And I'm a pretty bossy person. So, I mean, I was gone. And Peter was reading everything and believing that I would make it. As Dr., you know, Vivi made me feel that too. I mean, he did tell me statistics, and I have to tell you, I'm not someone, I hadn't yet told him not to tell me statistics, but I had already told Robos that. So he told me the first time I was there that I had a 20% chance of survival. And, you know, to sit in that room, hearing that, and thinking, okay, you know, what is this? I mean, why am I going to do this? And then all my girlfriends saying to me, you just fell in love. You have to do it. You know, and then, you know, I talked to Dr. Robos about it, and she said, well, you're not a statistic. She said, you have a really good heart, you don't have diabetes, you don't have a good liver. You know, she started throwing all this stuff, my insides that I knew nothing about, how great they were. And, you know, so, and then when I went back to see Vivi the second time, he said, you have a 40% chance of survival. We have, so, you know, this is really crazy because, you know, Peter and I have this argument, why did Vivi up the odds? We didn't ask him, we were always in too much shock in the meeting.
Robos told me.
That's what I thought. I thought Robos got on the phone to him and said, you tell her she has a 40% chance of survival, or you just up those odds, or do something, because I want this young woman old woman to go in and get this transplant. So I was quite excited to suddenly have 40%, even though I really did think it was Robos up to something. And it was, I have to say, it was as hard as any. I mean, I never had been sick before in my life, really, in that way. And when I got sick, I was in the hospital 100 days, and there was, when I was researching it to write my book about it, which my book is also a love story, by the way, because it starts with the loss of my husband and then the meeting of Peter and then this diagnosis. But when I really, when I went in there, I mean, within a couple of weeks, I could barely stand to go to the bathroom. And I have huge blanks in my memory. I have no memory of being in the ICU. I was in the ICU 6 days. And I was apparently telling everyone to F off. Everybody. I mean, the poor, wonderful nurses, you know, everybody who came near me. And, you know, my girlfriends all thought that was my inner voice protesting this absolutely helpless place I was. Because, you know, you're the center of attention in a hospital, but you have no power. So it's very weird. And then I went into the ICU and I ripped all my clothes off and I started screaming at them. And Peter came in and he covered me up and he was such a hero. But I did not know this. I have no memory of this. This was all told to me by my friend Meredith. So, you know, I had an adventure in that hospital of absolutely enormous, strange proportions. And then my lungs started to fill with fluid. And I'm not a depressed person, by the way. I'm actually a very bouncy person. And I was deeply depressed. I'd never experienced it. I understand now why people leave behind people they love. I mean, I just wanted out. And I was in an oxygen mask, and Vivi and Robos came to visit me, and Robo said to me, well, give me 48 hours, and if we get somewhere, give me another 48. Now, I consider this genius. She gave me hope and an end game in one sentence. I mean, that is brilliant for a patient. And I, because part of me, of course, did want to live. And then within about 48 hours, they had cured the lung issue. I mean, Peter stayed up all night watching those PO tubes and praying for them to go up. And they finally did, I think from being blasted with steroids or something. And it was just kind of, I woke up that morning and I just thought, I'm starting to heal. And it was true. From then on, I mean, I did have some setbacks. I mean, I think what did I have? Migraines. But I did not have serious graft versus host diseases. I really didn't. I mean, I had to learn to walk again. I was in a wheelchair. I couldn't stand up. I couldn't go upstairs, or I couldn't go across the room. But I really took that on. I had this great physical therapist who did not charge me that much, thank God. And I just 5 days a week, became an hour a day. And within, 6 months, I was back. It's a huge thing. It's as if you've been taken out of the world and put on a planet. And then you have to find your way back into this world. And everything is unfamiliar. And part of this treatment is you can't go on subways, you can't go to restaurants, you can't go to parties, you can't go to theater while your immune system is down. So you have really been eliminated from everything. And I mean, when I started to write again, it was like, the world came back to me. And also, I just want to say that writing this book, I think it isn't just that I get to read it and I get to read all Peter's emails to me when we fell in love and everything, and I get to fall in love with him all over again. But it's also, that I took that trauma and I got to make something out of it. And it's the thing that put this behind me and really allowed me to enter the world again. And I think for patients, if they can draw it, dance it, paint it, knit it, do anything with it, that it will help them because it's a journey. I mean, Peter gave me a tunnel of love a Valentine that was a tunnel of love, and he said, we're going through this dark tunnel, but we're gonna come out stronger. And it is a very dark tunnel, but there is light, and an amazing life is waiting for me. So thank you, Phoebe. Wait.
You make me miss New York again.
Let me show you. I want to read all this in left on. Anyway.
No, your book is great. We totally are recommending it. You might have heard Juliette's talk and the comments she made about there are many people out there who can't find a traditional donor, and that some doctors, even though that's true, don't think about doing a cord blood or a haplocord transplant. What would you say to those patients and those doctors? Two different things.
Oh my goodness. Well, I think the obvious thing is it's a fatal diagnosis. So you either want to take that journey and try and get to the other side, because it's genuinely another side. It's not, it's a real life you're being offered. And that is a huge thing. And, the young woman who I've met the young woman who gave me her marrow, who was my adult donor, and she was 28 years old. And she really thought she could save a life, And I was recently talking to the Be the Match people last week, and they were saying to me that people have started to say no to be donors since COVID. They're scared to go to hospitals to have transfusions. They won't travel to other cities. There's a national introversion right now, I think, in general. So, I believe if you've got a chance, you should take it. But I had the best care. I mean, Dr. Van de Zeen, he's fantastic. And
He's
I
smiling.
knew that I did. I mean, and I think that's the other thing they say. It's very hard to get, the kind of care I got. And I had medical insurance, by the way, through my Writers Guild union as well as Medicare. So I was able to get all my drugs covered. That's
I
a
mean,
huge.
I think that's very important, Delia. You got support. You got support from Peter. You got support from your family. That's exceptionally important. We've been talking about that this morning. And you had insurance. This is still too complicated. I mean, you did well, but as you say, you were sick. We wish we could do that with less sickness and with less trouble. But there's a lot to be learned. But also we need to make it easier for patients. I think the issue of 20% cure or 30% cure, very few patients turn us down because people want to live and people should live. But a lot of people don't have access to this type of treatment.
No, they don't. I know, I've been told that. So, I had great good fortune. I found Dr. Robos because another oncologist had done a bone marrow biopsy on me, and he said, "Oh, your sister should see Dr. Robos. She's just brilliant." And my sister was very happy with her SK doctor. So, and I thought, this was just when they were following me for years before, and I thought, I need my own doctor. I need someone who's thinking about me. And so I called Dr. Robos and made an appointment, and it was just these lucky things that happened, I met my husband because my internet crashed and I got so angry at Verizon. I wrote about it in the New York Times, and the next thing I knew, Peter wrote me a letter. So, I believe that there are strange things that can happen in this world, and I think luck really brought me to Dr. Robos.
Maybe I just say I'm a Jungian analyst. We call it synchronicity. It's not a mysterious force, really, as much as your own sense of meaningfully putting together what comes your way.
Oh, that's interesting. Like that. That applies to everybody in your room. Yeah. Truly, I don't know why I did actually. I know why I'm here. I know about this, but here I am in a conference being, because I survived. It's beyond imagining.
No, it's wonderful, actually. Can you describe what you know about cord blood? What you think it is and what it's doing inside your body.
Okay, well, this is actually even, it's the cord blood is when a mother gives birth, she donates her cord blood to, I assume, to the cord blood bank, right? It happens in hospitals which ask them to do it. And the stem cells are harvested from that, and there are very few of them. There aren't enough to immediately take over my marrow, so the adult donor has to take care of me during that time. I asked VB why the adult donor knew to go away, because it seemed to me that was real science fiction. and also metaphorically, like the mother taking care of the baby and then the mother leaving. Said they doctored it in the lab. So, is that correct?
More or less, but
It's a great way to describe it.
yes, that's right.
Yeah. But it's really because, well, we think, he gave you the adult cells without T cells, and the T cells helped the graft survive, and the cord blood had all the cells, including the T cells. So once it was strong enough, it could reject the haplo.
Oh, that's interesting.
And for some reason we don't completely understand, all the people in this room believe that the cord bloods are better in fighting the leukemia.
Yeah.
than,
Yeah.
than the adult cells. So that
Yeah,
we wanted
because
the
they're-
cord blood
they're
cells to survive because they are more powerful in preventing the leukemia from coming back. And I think your case is an excellent example of that.
Oh, okay. I also want to say that you should always realize that your patients are terrified and probably don't retain almost anything that you say to them. And that, you know, that whole thing they say, bring somebody with you. I mean, truly, that is an important piece of advice to a patient. Because there was one moment when Bibi said to me, you know, if you survive this 2 years, it's unlikely it's ever going to come back. And I heard it as, if you survive 2 years, it's likely it's going to come back. I heard the absolute opposite. And I left with this horrible feeling in my, you know, heart, oh, how many more months till it's 2 years? And I didn't say anything to Peter. And then one day I said to Peter, I said, well, you know, what Bibi said about how it's going to come back after 2 years. And he said, no, he didn't. He said the opposite. He said you're going to survive if you lasted 2 years. And honestly, you know, that is a huge flip.
Yeah, for sure.
No, right, that's me. I'm the child of alcoholics. I don't even know. I never believe in good news, but
Does anybody else have questions for Delia from the audience or from the podium?
I have just a couple comments. Hi, my name is Colleen Delaney. I am actually a pediatric stem cell transplant physician by training. But your story is incredibly inspiring, and I think it's incredibly important. I think it's great that you wrote a book. And I just have a couple sort of just observations about some of the things you said and some of the things that I say to patients and parents, right? So in pediatrics, it ranges from kids who, right, aren't, you know, you're really just talking to the parents, to young adults, right? Informed consent is one of those things to me that is almost a misnomer, right? How can you, as the patient, really be informed of something you don't know about? It's kind of like what you were just talking about. And I think that's a continuous process. As you said, you probably don't hear 20% of what we say. And the same thing goes for parents, right? We're dealing with a young person. And I always tell them repetition is the key to learning. At least that's what I told myself in medical school, right? That I'd have to hear it over and over again. And statistics, it's interesting that you say you didn't really want to hear that, because in my conversations with my patients, it's often not really about what that actual statistic is, because for you, as an individual, it's either 0 or 100, right? It's either going to work or it's not. And so, you know, I work very hard to focus them on the 100, right, that you're here for a cure, and that's what we're trying to do. And just curious, you know, if you can talk a little bit more about informed consent process. But one more thing, you talked about the letter, or the being able to meet your adult donor. And this is kind of, there are a lot of cord blood bankers in the room, and I try to bring this up a lot. I think it's incredibly, and I don't know if this is possible, but I haven't read your book, sorry, but in there, do you talk about the mom who, you know, I always wonder, what would you say to this mom who sort of donated their cord, not really even thinking about it, right? 99% of the time it's thrown away in the trash, but have you thought about, could you write a letter to this mom? And if she did, for those bankers out there, could it get to the bank and then get to the mom? Like, I think that would be unbelievably powerful.
Yeah.
As a woman who did this, really, when I gave birth, I was like, you could take whatever you want. I've got my baby, right? And you forget about all of that. But how powerful would that be, to be able to collect letters from cord blood transplant survivors, to be able to give them to the moms?
I think that would be fantastic. I mean, I did, when I wrote Casey McLean, who is my donor, lives on the Florida Panhandle, you know, I wrote her just my unbelievable gratitude to her for giving me life. You know, I thought about, did she care that I was older? Did she think she really only wanted to give to somebody younger? I mean, she didn't have any of those thoughts. She was very excited that she was in an experimental program too. She told me that, and she told me everything she had to do, which was quite elaborate, actually. I mean, someone came and gave a shot to her every day, and she flew from, Florida to Washington, D.C. She had to change planes in Atlanta. I mean, that is not easy, right? And she had to do it twice. And the second time, Be the Match sent her boyfriend with her when she gave the donation. So, I think for her, I have a picture of her donating her cells. It's so moving. She will not let me share it with anyone, but she's quite shy. But, or I guess. And Peter wants to, what did you want to say? Anyway, she's just, it was just so innocent. This 27-year-old in a t-shirt and her, just hooked up to 2 machines, and I don't know, it was amazing. And I would just say, at that moment of great joy in your life when you're having a baby, to also give a life to another person. I mean, how amazing is that?
I think that the point you're making, we're forever cut off. The cord blood donor is anonymous, but your idea of warming that up and humanizing that is fabulous, because when you think of it, that the mother and baby who donated that are at the portal of life and death, and then we want to bring other people through that portal into life. There's a way to humanize that you're onto, and I think letters, but I don't know, some representation of the mother herself to be delivered to the donee.
But even your voice, right? Your voice is...
It's the thing to do. That's the other thing. It's so,
Yeah.
I mean...
But even you saying, thank you, like, right here,
Yeah.
here, like, is there a way for you to video message? Or it's very powerful. And you are, I was going to say you were lucky, but you're never lucky to get diagnosed with AML, right? But you were fortunate in that you had such a powerful support, right? And so there are some patients who don't have that. And I agree with you. I think that is a lot of the battle, is knowing that you have that. And so your voice and your story, thank you for sharing it.
Yeah.
It's very important to those who don't necessarily have that right there. So thank you so much.
Yeah, okay, we'll let you have the last word, but we're at the end of our time, and I'm sitting here thinking we should just give all the maternal donors your book.
Oh, well, yeah, sure. If there's any way I can help you, I'm more than delighted to do that. So please know that, I'm on this train.
Yeah, well, we can't thank you enough. You were a great inspiration, a great way for us to end our conference. But thank you so much for answering my email first, and then for coming and speaking with us, and for just being you, and for telling your story, because it's really terrific. So thank you.
Thank you.
All right. Thank you so much for having me. I'm honored.
Okay, so you can keep listening, but I have to say goodbye to everybody. So I want to thank everybody for coming, for being here. I want to thank our speakers for all the wonderful talks. I want to thank Karen and Marcy and Nairi and Irina for making just a wonderful program, really. I think every year it gets better, but I think the biggest problem everybody complained of to me was, why can't I be in 2 sessions at once? Because we had so much good material going on in both places. I want to thank Alan and Dieta for making this all a reality. And also our sponsors and our exhibitors, and then all of you for coming, especially, the first time being together in now 3 years. And hopefully we'll be here again next year, and COVID will be less, and we won't have to worry about it, and traveling will be easier. So I look forward to seeing you same time next year. Bye.